It's the True Sports Physical Therapy Podcast. Tune in, you might just learn something. Catch all of the full episodes on all streaming platforms, and as always, the link is in the bio. In preparing for this conversation, I came across an awesome blurb about you, I believe from your alma mater, in which they described your philosophy as making every single one of your patients the star of the show. Tell me how you go about doing that.
That's a good question. I think it stems at least partly from approaching each individual without having an agenda. Truly, if you're looking at each person as an individual and you can take time to get to know them and you see the uniqueness that makes them who they are, and you genuinely start to appreciate, like, hey, this is a person that's got goals and aspirations, and whether they be athletic or, something as simple as, ADLs or whatever it might be, like I think it has to come from a genuine place of truly appreciating, valuing the person that's in front of you. And then practically doing that is, really trying hard to avoid to take the locus of control from them, right? Like you have to foster internal belief within them that they have everything they need, to get better, whether it be pain or performance or whatever it is. Because I think there's a lot of people out there that have this internal belief, and maybe I'm sure, with the PTs that are listening have come across these people where their projection into the future is negative. Yep. Their crystal ball projection about their adaptability or their ability to improve, either has been noceboed out of them, or they through personal experience, the positive outlook on, hey, I'm adaptable. I'm able to adapt to stimulus and grow and change. So if you are, I kind of look at it as like Yoda and Luke Skywalker, Star Wars. It's like, I'm the little green guy. I'm Yoda. They're Luke Skywalker, and they have the Force inside of them. They are the star of the show. They are the hero in this story. I'm just there to kind of like teach them, help them grow, put them in positions to bring that out. So
where do you come up? Like, where do you come up with that mindset?
That's a good question. Also, I think it's probably learned humility to a certain degree of just years of practicing, and learning to really trust people. And I think part of it, is my worldview to a certain degree of, I think that everybody's valuable, and their past experiences and their beliefs and expectations that shape who they are as an individual on the day that, the minute that they walk through your door, all that stuff is valuable. And so I think, I think all the PTs here at HQPT, and I try to embody this, is like really genuinely being impressed with the people that you work with, whether it's, a 70-year-old or a 90-year-old or a pro football player. It's like, it's all, everybody's a hero.
Yeah. It sounds like you embody the idea of service through selflessness. And I think that's one of my pet peeves of physical therapists, and especially in this like me first world that is so Instagram driven, where you'll see posts that are far more about the PT than they are about the athlete. And I think getting away from that is what sets you apart, or so it seems. I think that's an awesome lesson to PTs listening. Is don't forget why we went to school. We didn't go to school for ourselves. We went to school for our patients and for our athletes. And so that seriously resonates. I also noticed, looking through your website, you are conveniently listed dead last in the line of physical therapists. Was that by design?
It's funny you mentioned that. I didn't know if anybody would ever notice that, but yes, it is intentional.
Okay. And I think I know why, but tell me why.
I think that, it's funny. We have a thing here. So I'm sitting in my office. We're in Milwaukee, Oregon right now. And we're part of a big gym. It's like a 10,000 square foot facility out there. And it's an awesome gym. We love it. We're super blessed. And from day one, it's really interesting to see all of us park far away. You know what I mean? Like, it's kind of like you leave the front spots for the patients. And I don't know. I think it probably has something to do with that idea of just, like being humble and putting other people first. And I think on the website, it's actually cracking me up that you noticed that, because I didn't think anybody would ever notice that.
Yeah.
But I think it probably has something to do with just wanting to shine the spotlight on. It's kind of like the mirror, you just want to reflect the spotlight back on others. I don't know.
I love that. Now, you mentioned the culture you built and how you're all parking away from the building and it's patient first. And how do you identify that quality in an applicant? Because that is something that I effed up a million times. I was just hiring for the wrong skill, or I was looking, and it wasn't until I figured out, well, here's what I'm actually looking for. Tell me how you look for that patient first approach.
Yeah. So one of the big things I think of in this realm, and this might be redundant, but like the camping trip test. I don't know if you
tell me what that is. I live in Baltimore. I don't go camping a bunch.
Welcome to Oregon.
Yeah, exactly. Gosh.
Could I go on a camping trip with this person for a weekend and enjoy the weekend and come back afterward being like, I would do that again?
Yeah.
I know that sounds very subjective, and it is, but people, I would say, to be in a cash-based setting, if I'm keeping it totally real with the audience here, you got to be a little entertaining. Like people have to want to come see you. You got to be a little dynamic, right? And so, I can usually tell just sitting down and having a conversation. Like, my interview style is very conversational. I just want to get to know you. I want to see how you ask me questions and how we, what the back and forth and what's the dialogue like. And if I find myself and I'm like, gosh, I'm actually like pretty freaking fascinated by this person, that's a huge test for, if I think they're going to be successful in our particular setting. So we have, there's people from vastly different backgrounds within our setting, and the team we have currently, we sit down and meet, and we're like flipping each other crap, and we're having fun. And if that, you can get a sense on whether or not someone's going to walk in and be like, oh my gosh, what did I get myself into? Or if they're going to be able to dive in head first and enter that culture and add to it.
Yeah, for sure. How do you test their clinical acumen?
So we usually will do some, say working interview, but like shadowing.
Mm-hmm.
And so we'll have people come through and just spend the day with us, and I'll have them spend some time with Danny, who she's one of our amazing PTs, Danny Deloy, Jack Anderson, and have them just shadow us. We'll ask them questions. Hey, what do you think about this? What would you do? And that, you spend a couple days, maybe even just one, in the clinic, and get a pretty good sense of where they're at clinically. We also talk about, I think even something that we may talk about today is like, who do you follow? Who do you listen to?
Yeah.
What's your tribe? And you can typically get a pretty good sense about where someone's at for their tribe. But I'll also say, clinical skills can be learned to a certain degree. It's real tough to change, a personality, or just people that have been through things and have life experience and have grit and can overcome challenges. That's something that's harder to teach,
Yeah. One of the things that I started looking for, maybe this will resonate with you, is I love seeing athletic trainers on or an ATC on their resume. I don't care as much about CSCS. I don't care about USAW. It's nice. But when I see ATC, here's what I definitely know. They're hard workers. Yep. Because ATs, man, they just grind, and they are there forever. And they are, I'll never understand this, but they are squirting water in athletes' mouths for no reason. as well as doing the rehab. And so like it comes with far less ego. So I appreciate kind of seeing that. Give me feedback on my interview process, because what I do is I made up a case of an athlete that we see a million times. We have a shoulder case, an ACL case, an ankle case where they have failed rehab elsewhere and they're coming to True Sports because we see that like crazy. And I give that to them 2-3 days in advance. And then they come in and I'm the patient and they're the PT. And I like to see kind of how do they think on their feet? What do they do when the quad doesn't turn on? What do they do when the knee doesn't straighten or the shoulder's painful at end range flexion? So I get a sense for their clinical acumen, but also how adaptable are they? And that all happens in our very busy environment, which sounds like yours, which is a performance facility, right? It's not a PT clinic, it's a performance facility. And then I'm able to see like, how do they get in? My first mistake in that case was I used to spring that on them when they walked in and they would freak the F out, and that ruins everything. I just, I want it to be comfortable, but I want to test them like that. What do I need to change about that? Or what would you add on that?
Great question. I don't necessarily, I think we're after the same thing, really, kind of in our processes is like, how do you think on your feet? As we're going through, I have a patient doing a drill and I'm like, hey, what would you do differently? Or like, how would you dose this out? What would be your loading parameters for this? And, it's one of those things where when you're going through that with someone, you might actually, you as the boss man, might be surprised by their approach. And you might be like, actually, that's pretty cool. I don't even know if I would have thought of that. Like, that's awesome. So I do like it from that regard. You might, it might be a little bit different dynamic when you're evaluating your potential employer versus where there's that perceived like power differential, real or imagined or whatever. But, so it might be a little bit different than treating a patient where, they're genuinely, in a bad place. And so, it might be a little skewed, but I think it's really good. I think we're both after the same thing, which is, can you think on your feet? How comfortable are you talking through this stuff? Yeah.
Yeah, that's pretty awesome. Okay, good. Thank you for that feedback. True Sports Physical Therapy is growing like wildfire. We have 14 locations, soon to be more. We are throughout the state of Maryland. We're in Pennsylvania, in Lebanon, in York, Pennsylvania, as well as in Delaware, in Newark and Wilmington, Delaware. Like I said, so many more practices to come, and we always need outstanding sports physical therapists. Our treatment style is unique. We are one-on-one with your athlete for 45 minutes every single session. You do the entire treatment. You do the entire evaluation. And they are in state-of-the-art facilities where you have room to run, throw, and jump and really get your athlete all the way back to on the field and better and stronger than they were. We also have outstanding salaries, comp structures, bonus abilities, 401ks, as well as a very strong continuing education offering, including in-house continuing education. And we're looking for you. Now is the time, as we are growing like crazy. Just shoot your resume over to Yoni, YONI, at True Sports PT, or shoot us a DM, and we will hit you back. We will get you in for our unique, tried and true interview process and really make a determination that this is the right place for you to grow your career and get your athletes better than ever. We can't wait to hear from you. You nailed this segue. You did a manual therapy residency, and you're talking to a guy. When I came out of school, I was obsessed with putting my hands on patients and making them feel better. I just wanted to be the world's best manual therapist. And I took a left-hand turn once I started to get into some of the literature on manual therapy. Tell me about the most important thing you learned in your manual therapy residency. And then looking back on it, what do you think now was just total eyewash?
Yeah, I mean, I think probably the best thing I got from it was actually just kind of the model in the way that they approached orthopedic physical therapy, which they were very good in that manual therapy, that particular residency. I think they were good in teaching that a lot of the things we do in terms of special testing and manual therapy are not that special. And so I appreciated that they were like that early on, that it was more just a test, treat, retest model. And I thought that was really useful in terms of just like, can I reproduce my patient's symptoms, treat them, and then retest, and did their symptoms change? And let's not get really deep into saying it's this mechanism or that mechanism that changed them, because I've been in other programs where they do think, oh, you can palpate this and find asymmetry, and when you treat it, it's going to change their alignment or move this thing biomechanically. And I just think the evidence doesn't support that.
Yeah.
And so I've been exposed to different groups. I had my manual therapy residency, and then I did all the courses. For a while, I was at Texas Tech doing a doctorate of science, and I did the COMT through another group. And that group was very specific. And I think any program like that you go through, as long as you go into it with the right mental framework and have some knowledge of the evidence, of course, you're going to get good things from it. But I think you have to kind of put that stuff in its place. And the second one I went through, they thought we could be more specific than I think we can based on the evidence.
Yeah.
And so I think the thing that was the best of those residencies was just thinking about the kind of this principle, like I said, of kind of test, treat, retest, and just kind of keeping it simple. Probably the downside of those programs were the ones that I think what we're seeing in the research is that we can't be as, like, if you're, one of those programs initially would have said, would have taught us like looking at ASIS, PSIS, like up slip, down slip, anterior, posterior rotation, like looking at pelvic asymmetry, leg length asymmetries. And I think the more we look at that research, we see that people have asymmetries. They just have bony asymmetries for one. And expert clinicians can't identify reliably. They don't agree on these visual changes. So I think I am way less specific these days in terms of kind of like my manual assessment, posture, looking at alignment and structure. I just don't spend as much time on it. I'd rather just be able to see if I can reproduce the person's familiar symptoms, because I think that helps guide me. And then, maybe and I do way less manual therapy than I used to. I used to be in a clinic where literally they came in and every patient, we just did 30 minutes and then they went to someone else for the exercise. So it's like, I'm just doing manual therapy all day. And I'm not like that at all anymore. I mean, there might be something where it's just a few minutes to try and kind of help desensitize something like that. But then it's really, we know movement and exercise has the best evidence. So getting them moving, gradually loading, thinking about kind of graded exposure, just in building capacity, especially through resistance training. But that's kind of, I do less manual therapy than I did early in my career.
I mean, you use the term desensitization, which to me screams more of a neuro input than anything else, and biomechanical input for sure. What would your residency instructors say should they hear you talk about, I'm going to desensitize the structure before I go out and load them?
Yeah, it's interesting to think about. The person who taught my initial residency is fully on board that. He teaches pain science now. And so I know I don't know if we went back to that year, 2008, when I did that, he'd probably be like, what are you talking about, bro? But I think where he's at now, and his education followed the evidence like mine did. I know now he's like, oh, that totally makes sense. You're providing a novel input into the nervous system, and that's probably changing the pain output more than we're changing the structure or quality of some tissue or moving some joint to a different position, any of that stuff.
Yeah, which by the way, correct me if I'm wrong, that would, I would think, support any joint manipulation we do in terms of giving a different input to the nervous system to allow for either better range of motion or decreased pain through range of motion versus I'm going to realign, things of that nature, right?
Yeah, for sure. Yeah, I think so. I mean, there's a lot of fighting about, the efficacy of things like spinal manipulation and different mobilizations and things. And I get it. I get, where that's coming from, whether it's, if you're looking at, is this a non-specific kind of placebo mechanism, or is it something that's happening at the tissue level? I'm sure there's a mix of that happening with every person. And to me, sometimes I just think, as long as it's not coming with some harmful message that creates dependency, if it only takes a few minutes and it helps knock pain down a little bit so that you can start loading them and moving them, to me, it doesn't seem like that big of a deal. As long as you're not saying, hey, you have to do this, I'm putting your spine back in alignment, you've got to keep coming back so I can set you straight.
Yeah, I think that makes a lot of sense. So tell me where dry needling plays a part in your practice, whether you guys do that. And then also I would lump in cupping and instrument assisted soft tissue work. True Sports Physical Therapy is growing like wildfire. We have 14 locations, soon to be more. We are throughout the state of Maryland. We're in Pennsylvania, in Lebanon, in York, Pennsylvania, as well as in Delaware, in Newark and Wilmington, Delaware. Like I said, so many more practices to come, and we always need outstanding sports physical therapists. Our treatment style is unique. We are one-on-one with your athlete for 45 minutes every single session. You do the entire treatment, you do the entire evaluation, and they are in state-of-the-art facilities where you have room to run, throw, and jump, and really get your athlete all the way back to on the field and better and stronger than they were. We also have outstanding salaries, comp structures, bonus abilities, 401ks, as well as a very strong continuing education offering, including in-house continuing education. And we're looking for you. Now is the time, as we are growing like crazy. Just shoot your resume over to Yoni, YONI, at True Sports PT, or shoot us a DM and we will hit you back. We will get you in for our unique, tried and true interview process and really make a determination that this is the right place for you to grow your career and get your athletes better than ever. We can't wait to hear from you.
I don't do any of those modalities, and that's not really because I don't really have anything really hugely against them. I mean, when I was writing the book, I kind of went through, kind of refreshed my memory, just went back and looked at current studies on dry needling and acupuncture, and I think there are some showing that it does better than sham, some newer studies. So in California, we actually can't pierce the skin, so I'm not even allowed to do dry needling.
That's ridiculous, Tom. Yeah. Change that immediately.
Totally. And, but I do think, like manipulation, like massage, like, look, if you're going to do any kind of soft tissue work on people and then criticize dry needling, acupuncture, and cupping, I mean, there's a problem there. There's a conflict because massage is giving the same type of novel input into the receptors in the skin, just like cupping would, acupuncture, dry needling. So I think you'd be a little bit of a hypocrite if you'd say I do any of these other types of manual therapy, but don't think there's any evidence for these. I mean, they're still affecting the skin. So I'm not against those really. It's just that I can't, for one, do dry needling in California. And then in terms of like cupping and any kind of like scraping of grass, I just haven't taken courses on them. So I think I haven't ever felt like I needed to add that to what I do because I felt like I could accomplish those things with my hands-on skills. And then I'm obviously just going to move them towards exercise anyways.
Yeah. I mean, I think that makes a lot of sense. I've come a long way on the dry needling world. I have a sister-in-law who is a tried and true acupuncturist, and I thought she was absolutely full of crap for a decade. And then once I got into needling and saw my ease of joint mobilization manipulation following needling, and I realized what the impact needling can have locally, at least on muscle tissues and muscle tension, I really became a strong believer. Another thing that I have found good use for is aggravating those tissues to incur blood flow to allow it to withstand more pressure. And I've seen good use, like with a patellar tendonitis that's having pain with knees over toes stuff, to needle it and then take them down to the gym. And all of a sudden they're able to do more. At least I have found a role for it. Why the hell is it not allowed in California?
Yeah, I think it's just the lobbying power of, partly, I don't know if it's the AMA so much, but more just I think it must be the acupuncturist. It must be money. I feel like it always comes down to those things. I don't think the physicians probably really care about if PTs are doing dry needling, but I think the acupuncturist must have some money and that sort of prevents it. But I agree with you. I've had dry needling done, and I think I'm normally a really skeptical person. So I go into most things, I feel like being a little more resistant to placebo, that's the science side of me. And when I was practicing in Colorado for a little while, I had one of the other physios there did some dry needling on my levator at one point, and it was interesting. I could see, like you said, a role for it. When you have something that's acute, you can get in there and have some local effects on something or interestingly, you say like maybe being able to create an inflammatory response to kind of get some blood flow in the area, and maybe that reduces some sensitivity so you can load them. I could see places for it.
Yeah, and I think it's like so many things. I think PRP is an awesome example where you got to be careful that you don't just become the PRP guy or the dry needling guy where, hey, this is all I do, and I'm going to apply it to everyone. I think you just have to be sensitive and intelligent upon when you do those things. But that brings me to my next question, which is around biologics. Tell me what you're seeing with the PRP stem cell world, how often you're seeing it, and how much of an effect do you think it has one way or another?
Yeah, I think like you're kind of alluding to there, I think it can have its place, but you don't. I think there's a physician buddy here that I talked to that spends a lot of time in the world of continuing education related to PRP. He's mostly a hip surgeon, but he does use PRP with a lot of those patients that meet certain criteria for kind of pain relief. And I think, again, even when I was writing the book and going through, I have a whole chapter on complementary and alternative medicine interventions. And I went through and looked at the current research on PRP and stem cell. And I think a lot of it was still going back to this idea that it can have a role when it comes to relieving pain. But often the issue is that the formulas aren't standardized. So if you go see different physicians, there might be a different formula for it. And so maybe there is a particular formula that really has great efficacy, but maybe we just haven't found it yet. And I seem to see this. There's another physician, orthopedic physician I talk to on Instagram from time to time, and he kind of specializes in this area. And he's kind of said the same thing. He was one of the authors actually on one of the studies. So in terms of patients coming in, again, like how much of it is them, if you believe something's going to help you, it's probably going to help you. And so I've had a mix. It may be split. I probably have had a split mix of people who feel like it was like really hugely helpful and changed their symptoms and allowed them to function better, and other people who are like, didn't do anything.
Yeah. And I think the other caveat there is the shutdown period following. So how long is that shutdown period? If you're treating a tendinopathy, would they just have gotten better by putting them in a boot if it's an Achilles tendinopathy versus the biologic intervention? You make a great point, which I think is totally worth noting, is what do you mean when you say PRP? What are they actually spinning down? What are they actually putting in? I think there's so much gray. I think it's really naive and novice for us to think we have figured it out when it's so hard to test. It's almost like a diet across a massive population. There's so many other factors that we're not calculating. I think it's worth diving into. You mentioned your book, Rehab Science, and it is a monstrosity, as my mother would say. It's massive. And so like, as you were putting together that book, which, correct me if I'm wrong, is really like a Bible towards given pathologies that you see and how to treat them intelligently. And so when you went through that and you're basically doing a massive lit review on every pathology, what opened your eyes and be like, Jesus, I was wrong on this?
That's an interesting question. Yeah, I mean, the book kind of breaks down. It's got the first initial chapters on pain, then injury. So looking at all the kind of separating those, where are pain and injury similar, where are they different, looking at that research again, and then going through all the different sort of the conditions that I would see commonly in the orthopedic kind of outpatient clinic. And, but yeah, you asking about what stood out to me as I went back through things, I think honestly, the things that stood out to me were the complementary and alternative medicine type interventions, because I just hadn't spent a lot of time reading those. I just was looking at people on social media like, acupuncture's got some, dry needling has some research. It's all bullshit. Don't do it at all. And so it was interesting for me to actually go back through and kind of look at current research. And I think acupuncture was one that was surprising to me, where finding some newer studies where it did do better than sham. I thought that was interesting. It's not that surprising. It's kind of what I felt at a gut level, like we were talking about. If it's gonna provide some novel input, why couldn't it change the pain experience just like manual therapy does? So, and movement does. So, I think that topic area, going through all of those, we kind of went through and ranked different types of complementary and alternative medicine interventions in a hierarchy of what had more evidence down to kind of what had less. So things at the top were things like cross transfer and like visual, like mental imagery, things that, there's more research for. What else was up there? Oh, I can't even think of what else was at the top. It seems like everything I just want to put at the bottom. But of course, like at the very, so I think that was probably the area. Most of the actual conditions, I don't feel like I came, which was, I guess, probably encouraging. I came away from it generally feeling like I had going into the book.
Yeah. Well, so at least it's validating. I would say, like, when I sat for my OCS exam, it's really what turned my head away from this sacroiliac joint mediated pain. I'm like, what the hell have I been doing for the last 5 years treating SI joints when the literature doesn't even support my ability to feel where it is, let alone the patient, let alone another therapist. So that kind of opened my mind. I think it's a strong point, whether you're going to write your own book or whether you're going to sit for a board examination. It's such a great refresher to actually sit and read the literature, not read someone's take on the literature, not read an Instagram post on the literature, but to read this full body of literature that we have at present day, which is always evolving. And then to, hey, am I going to be humble enough to change the way I treat? I think that was really hard for me, just from an ego perspective, to think, man, like all the patients I thought I quote unquote fixed, I was probably doing something else. It wasn't me manipulating their SI joint.
Yeah, that's a huge one. I mean, I had the same kind of change away from that, where I used to spend a lot of time looking at leg length asymmetries and pelvic obliquities and trying to assess that stuff visually. And, I got to make sure I'm standing on the right side so that my dominant eye is looking at their pelvis, and, and implementing interventions where I thought, okay, you've got a anterior rotation your right side or posterior rotation your left side. I'm literally going to do this muscle energy technique, and your pelvis looks better. Like I'm rechecking it. I really believed I was doing all those things. And I think I agree with you. We just can't be that specific, and we're probably not changing things that way. SI joint pain, I included it in the book, but what I did was I didn't make it its own separate thing. I included it in the low back pain program because ultimately at the end of the day, I think that the basics help most people when it comes to movement and exercise. And so if you can teach people, again, like how to identify their aggravating activities, identify triggers and things like that, and how to kind of learn some of these principles so that you can modify a program that allows you to challenge the area of sensitivity in graded doses, whether you have back pain that's potentially due to a disc insult or a facet joint or the SI joint, the programs ultimately kind of look very similar. So early in my career, I probably wouldn't have thought that at all. I would have thought SI joint needs this very specific type thing that's different from like a facet joint issue or a back strain or something, but that's how you evolve, I guess.
Yeah. And I wonder how much of that is we make things so complicated so that we can be the experts, or one given person can be the experts. And when in fact, so much of it is so simple. So I think there's a ton there to kind of chew on. And if your Instagram tells somewhat of a truthful story, you spend a lot of your time with professional athletes. How did you get to that?
I think the biggest thing was, so I have a CSCS, but the CSCS is nothing more than just like scratching the surface in terms of where it creates a baseline, but then now it's like, how creative can I get with this baseline? Right. And I think at that time, Instagram was just starting to blow up. I didn't really use Instagram as a way to market myself per se, but I had a couple athletes that I was working with through some internships that I had while I was at University of Miami working with some of their athletes there. And, it's a D1 school that is a huge producer of NFL athletes. And, there's a lot of agents that kind of hover around there. And just like I said, through my own networking experiences and that sort of thing, rubbing elbows with these guys, it turned into like, hey, why don't you train this guy a little bit? Maybe do some linear speed training with this guy. I helped one other guy get ready for his combine prep. So it was just like here and there kind of dabbling into it. And then it's word of mouth from there. And then once that turned into word of mouth, is like, I always tell my PTs, one patient equals 3, because if you're doing a good enough job, then they're going to talk to their friends about it. And they're going to, send their people over to you. So that's kind of how it spiraled.
That sounds like a great spiral. Aside from one patient turns into 3, I think that's great psychology, business advice to start with. What advice would you give to someone who wants to be where you are? Like, give me the one pearl that to the sports therapist that's listening to this pod that says, man, I want to run something like Crew Lab. I want to treat that demographic or population. what's your one piece of advice to them?
My one piece, this is a great question, but I have a lot, but I would say demonstrate value. You have to demonstrate your value. People think that value is inherent once you get your DPT, or once you get your CSCS, or once you get your your SCS, whatever it is. They think that the value is there, and the unfortunate reality is that's what gets your foot in the door, right? So it's just like an MD or a DO. Like if you're going to be the world's best surgeon, you don't just step out of your surgical residency just because you earned it and you put the time in there and you have an MD. Doesn't mean you're the best surgeon now, right? Yeah. You still have to demonstrate value. So I think that is overlooked tremendously. And I think that we're in the age of fraud right now, where people could film for 3 days straight and make it look like they have a lot of value. And then when I walk into a meeting with them and we start a discussion, I quickly realized that there is no value there. They just had a branding team that helped position them in a way that made them look like they had value.
Yeah, I think that is awesome advice. And I think it's so important to take that advice and also apply to the person in front of you. What is the value that you think they need or want, as opposed to the value you think?
Yeah, so it's actually twofold. So you're saying the up and coming clinician, what kind of value do they need? You have to have, it's not your arsenal, if that makes sense. So I don't care that you took a kettlebell class. I don't care that you took some type of Bosu ball balance proprioception class. I don't care that you did the FMS screen. I want to know how you integrate it and make it something different. Yeah. Because athletes learn extremely fast. So something that I teach an athlete within 20 minutes, it probably took me 3 months to get that down. And then I teach it to them in 20 minutes and I'm like, shit, how do I make this harder? Yeah. How do I progress this? How do I progress this? How do I make this more? Okay, what other element can I add in here that's going to create that challenge? Yeah. And it's about protecting the athlete, number one, but also providing that stimulus and that challenge. And you have to exist within that window. So it's not necessarily what certifications you have, but it's more so how you apply it and how you add your own level of creativity to it and keep it within that bell curve of not challenging versus too challenging and putting them at risk.
Yeah, and I think it's a small nuance, or I'll piggyback just a little bit, which is sometimes it's so much easier to progress and make harder that exercise, and you have like a hulking linebacker, you want to make it very difficult. I think it's another level. If it took you 3 months to learn how to do that, it probably took you 6 months to learn how to make it easier. Like, how do you scale these things, right? Yeah. To still challenge it? Because that's when I know clinically, that's where I run into some issues is, crap, this athlete, this is way too hard. It's way too hard for them. How do I make it easier, still achieve the goal, and make it safer, right? And allow them to do it and still challenge.
I love the fact that you brought that up, because I was just teaching this to a student of mine that we had come through. But, this person's coming in 2 weeks off of a ACL repair. And we had bone, patella, tendon bone. And, we want to challenge this athlete in a way that they find value in coming to us, right? Versus going to a hospital-based system. We're a self-pay hybrid model. But you could take that athlete and make them throw up in their first visit.
Yep.
And they still have their stitches on, their dressings on from the original surgery. Mm-hmm. And, you just made them sweat so hard and throw up and vomit just because you provided a stimulus that had nothing to do with the knee. Mm-hmm. Right. And and not that you have to do that, but I'm not encouraging people to make their athletes throw up within their first visit. But what I'm saying is,
that would be a good title for the pod. Right. How to make your athlete puke.
Very, I got to put that disclaimer out there for sure. But no, it's really important that, like you said, when you scale it back, okay, that's great, but how do I make this still feel like a workout for the athlete, that they're engaged?
Yeah.
Right.
Yep.
Because keeping them engaged is half the battle.
Yeah. Yeah, absolutely. I think that's great advice. It's great business advice. It's great sales advice. I think you're on the money with that. I want to get a little clinical. So with the fact that Crew Lab deals with so many professional athletes, these athletes, and by the way, high-level professionals, whoever it is, have very tight schedules. They have demanding training regimens. How do you ensure compliance for this athlete? How do you make sure whatever it is you're prescribing, they're going to have time to do it? And then overlay that maybe with they have an overuse injury, so they're already kind of in the red. How do you get them to, one, buy in, and two, be compliant and not piss their tissues off?
Well, the buy-in, I think, comes from laying out the whole program in front of them, right? So that's really important, that they see that you have an idea of, you have a framework, you have a skeleton that you're going to be working off of. Like it's just like any other ACL protocol. But, within that, I'll say, okay, we're also going to be doing uppers on this day. We're going to be doing lowers on this day, whether it's upper push, lower pull. We're going to be doing more cardiac output, stuff on these days. These are the different, this is our menu block to pick from in terms of, what we could do to challenge your cardiovascular system without, pissing off whatever your injury is and all that kind of stuff. So showing that you have a plan is number one, right? To create that level of buy-in. Mm-hmm. But specifically the athlete that is already a pro, not the ones that are going pro, but the ones that are already pro. I mean, these guys have different events to get to. They got OTAs. They have, OTAs we already planned for, but it's mainly the travel schedule that they have to deal with, and flying all around. And it just seems like there's just never enough time to get it all in. And the hardest part with that is that it's like a lot of times I just have to have constant check-in with these people, okay, what did you do between Monday and Thursday? Like, who did you see? What did you have done? I have certain athletes that they see 5 different clinicians, right? This guy's the guy that I like crack my neck. This is the guy that I like crack my back. This is the guy that I go to for dry needling. This is the guy who I go for neuromuscular therapy. And it's like, dude, I can do all those things. But it's if they want to tap their head and rub their stomach and it makes them feel better and feel like they can run a 4.3, then guess what we're doing that day, right? So it's like, I'm not going to convince them otherwise. There's a certain level of patient education that you have to do, but I'm not going to sit here and be like, oh, okay, well, you have to get your neck cracked with me, and you got to do your dry needling with me, and you got to do your strength and conditioning with me. Otherwise, I won't see you. It's like, you got to play within the boundaries that they want to work in with it as well. These are grown men. So when it comes to a younger athlete, I just wish that they had more guidance as a younger athlete of like, being able to put your trust into one person. But I would also say that, South Florida guys are a lot different in the sense of, they were exploited as young athletes very, very quickly. Yep. And you can take an athlete, these guys are people down here, like half these athletes that I've worked with, were adults, their own parents were betting on their games, at 12 years old. So it's like you're being exploited very quickly. And it's like, it's very hard to trust to establish that level of trust. Try to find me some kid in Pennsylvania, in my hometown, that somebody bet on his game when he was 12 years old. You're not going to find it. So they're much more, inclined to trust you easier, which makes my job a little bit easier. But in terms of taking an athlete and building that trust and working around their framework, I think you have to show that level of flexibility and that you're willing to be flexible with them. And sometimes it's not perfect, and you got to be okay with that as a clinician. You got to be okay with the fact that it's like, okay, I've been working on this kid's knee. We're trying to get this lesion to go, to subside and the swelling to go down. And we're trying to build the quad back up. But he's only coming in, sporadically. He's here 3 days in a row, and then he's gone for a week. Then he comes back for 1 day, and then he's gone for 2 weeks. It's like the best that I could do is give them a protocol to work with, and then make sure that I have a line of communication of whoever they are seeing so that they understand what I did last.
Yeah, that last piece really hits home for me. The idea that it's rarely perfect. You're rarely rehabbing in a perfectly sterile situation where you get all it is that you want. It is the concept I just read about called wabi-sabi. Wabi-sabi is the idea in Japanese architecture that there will be imperfections, and we almost need to celebrate those imperfections and understand that that's the real world versus this like cookie cutter CSCS DPT world where it's like, here's the algorithm and the protocol you follow. These guys got to get on a plane. They got to run out and sprint. You got to celebrate some of that and include that. I think that goes a long way. Let's get even more granular. So the athlete comes into Crew Lab. He's got anterior knee pain. Let's call it patellar tendonitis. He is a professional athlete, so he's involved in everything you just described, whether it be flight and travel and other rehab guys and in-house strength, right? How do you go about assessing that athlete biomechanically? And what do you think your first interventions are for this rip roar and patellar tendonitis?
Well, I mean, my first go-to is usually our force plates, for something like that. And just detecting asymmetry, but everybody has to go through a table joint by joint assessment with me. And we do that with, I use a microfet too. I just find it to be the easiest if you want to get into the actual tech that I use.
Yeah, tell me what that is. Tell us a little bit more about that.
Microfet 2 is just a handheld dynamometer it's very like biomechanically speaking, it just fits right into the palm of your hand. And like, I understand Vault has a dynamo. I understand that Kinetech has different products that they use. You have the Tindex system is another good one. It's a pull only. It's not a push system. So however you decide to rig it up, you just got to rig it up so that it pulls apart instead of pushing together. This is what's going to help you to detect the nuances of number one, rate of force development, and number two, asymmetry, and number three, absolute strength output. But it's also, there's imperfections there because like when guys learn how to take the test better, they score much differently. And that is the problem that I had with, and I'm not trying to I won't say the name of the company. How does that sound? Right. But there are certain systems out there that will create like 3D models of you, and watch you do a functional movement screen and measure your distance and your joint angles, with an overhead squat versus a back squat versus a lunge or whatever it might be that you're testing. And this we call motor morons, which means, a patient comes in, the athlete comes in, and we're like, okay, go ahead and squat. And it looks terrible because they're not warmed up. They're not activated. They're barefoot. They're not in their typical shoes that they wear when they normally squat, whatever it might be. Nothing's turned on. Nothing's activated. I just try to be as consistent as possible and just watch them squat cold. Right. And then next thing I know, we go through a whole workout and then I put them through the same exact test and the results look completely different. Mm-hmm. So it's like, that is not an accurate test to me. Sure. So I don't really care what the person looks like when they squat cold, especially like you're talking about if they got a hot knee like that. It's like, I already know it's going to look like shit. Mm-hmm. So, you can say the same thing with like, are you doing gait analysis? Like, yeah, I'm doing gait analysis when the gait looks normal and I actually want to change something. But if the guy got a hot knee, guess what? His stance time is going to be decreased and his stride length is going to be decreased. Great. Now what? Yeah. Right? It's like the same stuff. So when people ask me if I'm doing all these things during an assessment, I'm like, I already know he's going to favor the other side. Mm-hmm. So I could use that as a baseline, but how much of how long do I want to keep the athlete? How many of them all came in at the same time? Because they come in waves, by the way. It's very rare they come in by themselves. So they're coming in waves. I battery test, and then I do what I can with that test. And I guess call it experience. You've been doing it long enough, but it's like, really what I want to know is what are the nuances between the joint differences and how your body is moving because of those joint differences. So what I mean by that is like, if you have limited dorsiflexion, do you have limited dorsiflexion because your talus joint is stuck? Or do you have limited dorsiflexion because your gastroc is tight and your knee is locked out? Or do you have limited dorsiflexion because you're in a poor positive shin angle because your soleus doesn't want to take eccentric control of the forward shin angle? So there's 3 or 4 different ways that you could be stuck. Do I have a bony block? Right? Yeah. There's a lot of different ways that you could have limited dorsiflexion. So really the assessment just comes down to find the quick and dirty, what's stuck and what's weak, and then find out what's making it stuck and weak, and then develop your plan of care from there. And I think that is the passive range of motion is the number one. I tell this to all my students. Passive range of motion is the number one most underrated special test that there is. Okay? Because if you can't bring your arm up over your head, how many different reasons are there that you can't bring your arm up over your head? Tight lats, a bony block at your AC joint, bursitis, frozen shoulder, inferior capsule. And it's like, okay, well, they're stuck overhead. Maybe they don't have strength. Maybe C4 shot, C5 shot. Okay, so maybe it's coming from the neck. There are so many different things going on there that it's like, but you went and you watched a YouTube video on like their arm is stuck and they have a mobility problem, and let's go and stretch with this band that's going to, pull you this way. And then you're going to activate your SA and then let it go. And then you're going to stretch back over. Dude, I make those videos. So don't get me wrong. All right. So
I've seen those videos.
Exactly. But what I'm getting at is that the passive range of motion component of finding out why somebody can't reach overhead dictates how you're going to treat this person. Because that banded stretch, it means nothing if they have a bony block. It means nothing if they have, an anterior capsule problem, right? So there's that's why we got to get to that granular level. You start macro and then you go micro and then you develop the plan of care from there.
So what you're saying is if they don't have it passively, it doesn't matter what band you add to them. It doesn't matter, what trick you do. They're not going to get it actively. So first assess whether they have the motion passively. Does that sum that up?
Oh, no, I always start with active range of motion, right? Because if they have a motor control issue, you got to know that too, right? Or if it's a weakness issue and a neuromuscular pattern going on. But so I always start with active, but once I get to passive, right? If they can't do it actively, first of all, if they can get there actively, like what do I really care unless they're hypermobile? I don't even really care to do passive. But if they can get there actively and everything else looks good, there's not overcompensation somewhere else. Like I don't really need to dig into that too much further unless they're complaining of pain there. But like I said, I go through a full body analysis when these guys come off the field because they're wrecked. So from a season. So if I do notice limitation after active range of motion, that's where I say passive range of motion is your number one special test, because you got to use passive range of motion to understand why they're limited. Is it poor neuromuscular control? Is it weakness? Is it stiffness coming from muscle tissue? Is it stiffness in the joint capsule? Is it a bony block? There's only so many things that could be blocking that full range of motion, and you need passive range of motion to determine what that is.
And clearly I'm not the brightest in this phone call. So explain to me if I'm missing something. Wouldn't it make sense then to start passive? Hey, you don't have the knee flexion you need passively. So we got to work on that before I start going down the active route. It doesn't matter if they don't have it. If they don't have it passively, they're never going to get it actively. It's not there.
If they don't have it passively, they're never going to get it actively.
Correct.
No, I would argue the other. If they, again, like let's say it's a boggy knee, right? The knee's swollen. Just because I passively push you to 110 degrees doesn't mean you're never going to get 130.
No, you will get there, but you're not going to get there if you're at 110.
Oh, actively, yeah.
Yeah, you're not going to 120 actively.
I see what you're saying. Yeah, for sure. But wouldn't you want to know what their hamstring strength looks like anyway?
There's no question, but I can't come up with some type of intervention that's going to change an active insufficiency if they truly have a passive insufficiency. So your example,
agreed.
Okay.
Yeah, no, agreed for sure. But what I would say is that I would want to make sure that there's no apprehension first before I start pushing the limb into a motion.
Fair, yeah.
That would probably be the only reason why.
Okay. Hey guys, quick pause and a quick shout out to this new masterclass that we just launched here at True Sports Physical Therapy. Myself and Dr. Tim Stone put together a masterclass of ACL rehab, and we call it From Table to Turf. And the reason we call it that is because it's going to teach you exactly how to get your athlete all the way from post-op day one with the nitty-gritty of regaining all of that range of motion with the tips and the tricks that we use here at True Sports Physical Therapy that gets our athletes better, faster, and stronger. And that's early. And then how do you progress that athlete all the way onto the field with a ball in their foot or a stick in their hand or whatever their sport is, and teach them how to accelerate, how to decel, how to change direction, all the mechanics that go in there. What drills do we use to get our athletes exactly where they need to be back on the field and even better than before injury? And I want you to sign up for that class. Now, you can find it on our website. You can shoot us a direct message and just say, hey, send me the course. It's right now on sale, so make sure you sign up now. It is fully accredited to get you all of your continuing education hours. Sign up for the True Sports Masterclass ACL From Table to Turf. Thanks, guys. You put up outstanding content on Instagram in terms of how you approach the athlete, how you blend these worlds of strength and conditioning and sports rehab, and that's what great sports PTs do. That's why I was super excited to get to talk to you. I want to dive into very specifically hamstring strains and tears and how you look at them and how you eventually get them back on the field. So if you could give me an overarching view of your approach to hamstring tears, how you grade them, and then how you walk them back onto the field.
Yeah. So hamstring tears across team sport athletes is probably one of the more common injuries. And I feel like, especially in football, it's one of those things that is talked about so frequently in the circles, in coming from postseason into the off season, as well as the preseason preparation and going into training camp. The number of hamstring injuries is just always one of those conversations that's in the mix. And you see this across NFL as well as the NCAA. It's so common that there has been so much interest in this from both rehabilitation. It's kind of bled into the academic circles, and interest in injury prevention as well as how to rehab. And when you ask about the process of grading, this is where things do get a little sticky. We typically, and I was the same in school, and I'm sure everyone else that may be listening who has been to physical therapy school, or even in your undergrad when you're learning like maybe some basic athletic training type things, or you're coming into any type of injury realm when it comes to learning about the hamstring, there's always the 3 grades. You have grade 1, grade 2, and grade 3. And grade 1 is kind of like these small little interruptions, maybe no bruising, just kind of some soreness that prevents, full function, and it's a little tight back there. And then you're expecting a little bit faster return to play. Grade 2 is sometimes maybe characterized as now there is a little bit more bruising. This is typically something that is seen as a little bit more serious. It's more disabling, if you will. And then a grade 3 is kind of this like catastrophic idea of this full rupture, and a lot of bruising, a lot of trauma. And those are kind of how it's seen. And I think that's an okay way of looking at it. But unfortunately, when we look at the predictive models for any type of prognostic or clinical tests when it comes to hamstring gradation, there's really a very wide variety in what comes out of that. And very little has been found from a clinical perspective, even MRI findings, on how quickly someone will actually return to play, and then what is their risk of re-injury. We know that a previous injury is probably one of the greatest predictors of being at a higher risk for re-injury. If just having a previous injury will put you in that greater risk category. We know that, but we don't know how much that risk is based on the clinical tests that we have. And what's funny is like when we look at studies that examine how does MRI findings compare to just patient perception of how well that they feel and how quickly they feel they will return, there's no difference in MRI finding versus how good the patient says they feel in return to sport, and the level at which they return to sport, and the level at which they abstain from a future injury. So all I mean to say is that it's not that any of this is meaningless. It's just that these are really complex issues. When it comes to musculoskeletal pain and injury, we've been finding things similar to like low back pain, where it's like, man, we really have to take a much deeper dive into what is pain, what is apprehension, what is fear. There's the major like motor learning components that are happening when someone goes through an injury. Cultural differences, familial differences, social cultural interests. Even if you have a family member or teammates who freak out when you have a hamstring thing, or you've had friends or family who have had major limiting disabilities or loss of careers or loss of season because of hamstring injury, and now you have a hamstring injury, that psychological component will play a factor in how fast you're able to recover and the degree to which you're willing to push yourself, because there's a higher amount of fear and apprehension. So when you ask about how do I grade these things?
Yep.
Boy, we know that what's funny, and in all the clinical testing studies that we have to date, there is a fairly high amount of bias that goes into that. But one of the most likely tests to change your pre and post test probability of a hamstring strain is the taking off the shoe test, where you're just putting the heel of your injured leg on the instep arch of your uninjured leg and trying to like peel the heel of your shoe off. That probably has one of the highest clinical markers related to MRI findings, as well as just overall ability to predict if somebody actually does have a hamstring strain. So I think the study by Michael Raymond, I can pull it up here, but one of the things that he talks about and his group talked about in the study that they proposed was that, hey, guys, we don't have great diagnostic accuracy in this. So really, it comes down to, let's rule out what it's not. Let's make sure it's not neural. Let's make sure this is not a nerve-related injury, that this is not coming from the spine. Let's make sure this is not like a femoral head stress fracture of some kind. Let's make sure it's not these other potential, like a DVT in some patients, maybe a clinical kind of indicator of something you should be checking for. But once you've ruled out those things and there's a posterior thigh injury that kind of pops up in something similar that you would expect for a hamstring injury, it's probably a hamstring injury. Yep. But the severity or how long that hamstring injury will last, the range of what we have, even in like something that may be a grade 1, ranges all the way from like 5 or 6 weeks up to like 20 plus weeks. I mean, the variation is huge across what we have. So when you're asking like, how do I grade it? Oh boy, it really is from day to day, from day 1 through day 2, 3, 4, and 5, and 6, as we just start early exposure back into some of the things which we'll get into. That's going to tell me a lot more of about how long this athlete will take to return to sport than any like clinical test that I could do on a table, or even MRI finding will tell me. So hopefully that, I know it's a long-winded, but
no, but I think that gives great context to the conversation we're about to have. But it begs the question, why do we grade them?
Yeah, I think we grade them to give people as well as ourselves answers. Think about every sport coach under the sun. Right, but everybody wants them.
Yeah.
And I think it's the same cultural issue that we deal with across other musculoskeletal injuries, where people want an image and they want an answer of, how many PTs, every PT out there who's listening to this will have, most of their patients will ask this question of, how long is this going to take? Sure. That's the golden question. When can I expect to be back? And the unfortunate truth is that there is very little information or data to suggest that we can give a very reliable answer. Even after I've been working with an athlete for maybe a week or two, I may give them a range of time, but what I'm trying to help them understand is that in the rehabilitative process, it's not so much about getting back to this ideal version of self that they have envisioned. It's about making progress. It's about, how can I improve myself today from where I was yesterday? Now that sounds kind of like, eccentric and kind of nice and very zen. And it's cool to tell patients that, but it's not very cool to communicate with a sport coach who needs to know, what game can I expect them by? So we have these grading processes, I think, and I think of it more of less like categorical and more of like a sliding scale. Like grade 1 through 3 can obviously just be a total spectrum, and you're just sliding that needle across a wave, versus like being placed uniquely, squarely in a specific category with a very specific time. But I do think it gives you some capabilities of a potential time frame that you're looking at. So
you just said it doesn't.
Yeah. And that's the thing. It's like, I'm trying to understand, if I grade someone, I have a general idea. I can at least, maybe, if somebody has to have an answer and a sport coach needs an answer, I can give them a range. However, here's the big however, is I would much rather give a sport coach, hey, here's about the time. However, I want them to be able to do X, Y, and Z. I want objective criteria that, and I can tell the coach by measuring certain things or testing certain things, I can say, hey, coach, listen, we're 2 weeks deep into this thing. I know this is what the athlete was able to do today. This is a Wednesday, right? He did this, 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 and this. I have this specific volumes. I have a specific test outcome measures. He needs to be here. And I give him the idea of where we're going. Now, you can, if it's been 2 weeks and he's made this amount of progress, we already know that about 70 to 80% of the way there is going to come a little quicker than that final 10 to 20%. It gets harder and harder because you have exponential diminishing returns on what you're going to get out of rehab and training. So that said, if we know that he's made this amount of progress in 2 weeks, here's maybe kind of an idea of the trajectory of where this is going, but he needs to hit these numbers or he needs to hit these clinical measures before I'm willing to say, hey, this guy's got a full green light to return to some OTAs, indies, that kind of thing. And I think that goes over a lot better versus time-based. And most research is actually leaning that way. We see this for ACL. We see this for high ankle type stuff. It's like there are clinical predictors of criteria-based progressions versus, oh, well, it's been 9 months since your ACL surgery. You should be good to go, because we know that that does not work all that often. And the quality of return to play can be variable depending on just time alone.
Yeah, listen, I think you make a lot of great points there. I think what I took away was the education piece, not just to the athlete, but to the coach in your situation. In my situation, I work in private practice. That education, it should be the same education. So it's to the parent, it's to the athlete. Here's where you need to be. And I think it totally changes the dynamic from the crap we got in school, which was what you previously said, which is, hey, it's a grade 2. It's going to take this amount of weeks. Whereas if you're putting in functional thresholds they need to get to, you're putting in objective thresholds they need to be able to do. You have to be able to explain that in day one. Here's where you are. Here's where we need to go. Let's see how long it takes. Hey, you've made this amount of progress. We're this amount there. I think there's a lot of great insight there. So I appreciate that. Why or where did you get all this business intellect? Because there's no way in hell you learned it at Marymount.
Yeah, no. So people will look. So here's as soon as I explain this to you, it's going to be really obvious. So when you run a radio station, you're in charge of picking, music and branding and the funny, the cool little sound effecty things that go between all the songs and stuff like that. You're responsible for everything you see and hear. Right. That's what you do. Here we are at the radio station. It's yeah.
Love the PT Pinecast? Yes. Support the show by telling a friend or by leaving a review on iTunes or Google Play.
So you do that all day long, right? Except that's not all you do, right? So you talk a little bit, you do contests, you give away beer and concert tickets. That's what people see. What they don't see is when I'm off the air, someone comes in and goes, hey man, Coors Light has $250,000 to spend this quarter. And we have to put up a proposal to marry our audiences. So now you have to think, how do I put together a creative plan to make Coors Light want to spend all or some of that money with me? I have to put myself in Coors Light's shoes and go, what's important to you? What do you want to do? Blah, blah, blah. And then tomorrow, the local Toyota dealership is coming in. Same thing. And on Wednesday, it's the local hardware store. So you de facto become the marketing person, or you're at least trying to be a partner with all these ridiculously different organizations that you're trying to partner with. Mm-hmm. So you learn real quick how to know your audience, put yourself in their shoes, identify what's important. Is this sounding a little bit like PT as well? It should, right? Same. So the parallels to me when I got into PT school, I was like, oh my God, this is similar.
I've already done this.
Remember the FIT principle in PT school, right? Frequency, intensity, time, type. And then they added frequency, intensity, time, type, volume, and progression. Those are communication principles. How often, how intense, what kind? These are media principles. So the business stuff came from when I wasn't on the air. I had to travel around with salespeople and be like, hey, this is Jimmy. You might know him. I went by my last name. This is McKay. He's the afternoon guy. He does the 5 o'clock block and he does the, ass backwards song of the day and all these. Oh yeah, I know him. Here's how we're going to take my show and the audience it has. Here's how we're going to make sure that they love you and they understand what value you provide. So you're selling there, which what you want to make sure you do is think of them first. This is where Gary Vee will throw out 51-49. He's like, I want to give them 51%. I want to give more than I get.
Yep.
And when you do that, you build relationships. And this again should sound like clinical care, which is I want to make sure you're getting or feel like you're getting more from me than I am from you, because that's the way we serve, right? It wouldn't have you come to my house and then be like, and then you hoard half of the stuff from you. No, what do? We give, what would you like? And that is the building of a relationship. So that's where I got a lot of if you can't understand the two sides of programming, which is what you hear, right? This stuff.
This is the PT Pinecast.
The programming and the music and everything. If you can't understand the marrying of that and the sales and marketing, you have a really cool radio station, but you can't pay rent.
Yep.
And when you understand that, you do. And now look at clinical care as programming and marketing and sales as the way you pay rent. If the only way you're doing that is based on what someone else decides you're worth as an insurance company, I'd get real nervous. You imagine that? My ratings in radio went up triple, but the FCC decides what I get paid? Are you kidding me?
So backwards.
When I say that, people are like, that's ridiculous. I'm like, that's what you do.
Yep.
That is how you're doing it. And I think now, hopefully, the trend is I want to take more of control of my business because I'm an autonomous practitioner. And you should. If you don't have those skills, hire someone, partner with someone, take a class, read a book, let's do a podcast, something. But it will raise the roof or the ceiling of what your clinical skills can bring you and what the impact you can have in your community. It's not just about money. You can decide you made $100,000 more than you did last year. Buy a wheelchair, ship it to Costa Rica. I'll love you deeply. So if you don't think I ask people all the time in PTs, are you in tell business or show business? And like, what's the difference? I tell people how to do exercises. You never show them? Because if you don't show me, I can't see it. You just tell me, I'll nod at you and then I'll walk away. But both of those are businesses. So you're not in healthcare, you're in the healthcare business. Because if you're not, it means you don't provide a value.
Yeah, freaking love that. Okay, so how do you prepare? I would ask it twofold. How do you prepare for a podcast conversation? Yeah. And then counsel me on how I should be preparing to interview staff.
All right, so a podcast interview, are you telling me something I don't know? So if you're going to interview someone and you're like, okay, well, you went to Duke and that's cool. That's nice. It's a nugget.
Not cool. Duke is not cool, Jimmy.
Oh, are you like is it like
yes, Yes.
Oh, sorry. Oh, yeah. Sorry. I forget. All right. You're right. So the question I always ask is the next question out of my mouth going to allow the person I'm talking to tell me something I don't know, or the audience really something I don't know? So there's this concept that you should understand, and so should clinicians. Again, the parallels it's called the curse of knowledge. And unfortunately, when you go through PT school, you have a lot of knowledge. And then you also have the curse of knowledge. Once you know how to read, if I put words in front of you, you can't not read them. You just start reading them. That's how the brain works, right? So the problem is you can't forget what it's like to not be able to read. It's difficult. I shouldn't say you can't. It's difficult to mindset to put yourself in the patient's shoes and go, they don't understand any
of this. Yep.
So you're on level 49 and they're like, they're being nice, they're being cordial, but they don't understand any of it. So I actively try to say, if the audience doesn't have any idea who this person is, because I've been reading this person's posts for 6 years and I got it, and the person's in front of me and I don't want to look like I don't know them. I set them up before the interview. I'm like, I might ask you some things that tee you up because I'm a batting practice pitcher. My job is to make you hit dingers. So it might sound like I don't know what I'm doing. I'll give you an example. Christy Wellington is a former, I think, 7-time Ironman champion. And I was a triathlete. So she started partnering with this thing called Park Run in the UK. It's like a nonprofit. Go out and run 5Ks. So I had an opportunity to reach out to Park Run and be like, I'd love to tell people about Park Run. And they go, sure. And I go, could I interview Christy Wellington? She's your celebrity. And they said, absolutely. Christy would love to do that. So now I'm like geeking out because I'm going to talk to Christy Wellington. She never ran an Ironman race. She didn't win. She was undefeated at Ironman. So I'm a little
big deal.
It's a big deal. So we're prepping the interview, and I don't want to. I want to make sure that she doesn't know that I'm geeking out. I'm trying to play it cool, and I'm sort of like setting it up before I hit record, and we're getting to the part where she actually is like, "Do you know my background?" Because she was like, I was like, sort of not. I was setting it up. I didn't want to tip my hand yet. And then the first question I asked was, Christy, I don't know if you remember this, but you actually beat me in my first 70-mile Ironman race. And you beat me by so long that you had time to go home, shower, put clean clothes on, come back to the race, and put a medal on my neck when I passed the finish line. How'd that feel? And the minute I said that, she was like, oh, you understand everything. These are setup questions. I'm like, right. Because my job as the host is not to look smart. Job is to set you up to get information out of you. And here's a lesson. Do you know Chris Voss never split the difference?
Sure. Legend.
Every conversation is a negotiation for information. Not a lot of conversations, not some conversations. Every conversation is a negotiation for information. Either trying to get someone to understand your information, or you're trying to get them information from them. When you look at an interview or a conversation like that, You instantly get better. The goal here is to either get you to understand something. Now I'm holding up a finger up for the podcast audience. If you move the goalpost as a physical therapist, and this was hard for me because I tied myself emotionally to the outcome. I need you to do something. I make suggestions. You make decisions. My goal is to make sure you understand if you do A, there's a good chance B will happen and you want B. So A is what we're going with. Instead of saying, well, the patient's not compliant or this or that. It's like, were you clear? Because that's the only thing you can control. Are you clear? Because you're going to leave and you're going to spend 167 hours out there before you come back next week.
Yep.
My only weapon is actually communicating to attempt to get you to understand. And it's like Inception. I need to make it your idea, right? Deviously, DiCaprio was like, I need to make it your idea. The way to do that was to try to understand the person deeply enough that you could plant the seed to say, if you want this, do that. But to quote my favorite Peloton instructor, Dennis Morton, I make suggestions.
Dude, that guy's okay.
I like him.
Why?
So I like him and I like Matt. And I can't remember Matt's last name, but they're like
Wilpers.
I like Wilpers a lot. I don't know. Every once in a while, I just like he's a palate cleanser. Some of them, the other ones, the dudes are they're over the top. He's a little hippy dippy over the top. I get it.
He's hippy dippy over the top. I can't deal with his mannerisms.
I know. I get I see where you're cringing on him. And I'm just like, you know what? Just distract me with maybe I laugh.
When you can have Wilpers, why would you ever go with?
Because I do ride a lot, so I don't like to ride the same ride twice. So I will go to Dennis or some of the other endurance PTs on there.
Yeah. Are you an FTP guy?
Yeah.
Of course you are. I don't even want to know what your freaking numbers are.
I retest. I couldn't tell you. With a number, I can't remember numbers 30 seconds. No, that's probably why I stayed in radio and things that's things that made me nervous in PT is like holding on to a number for me is like holding on to sand. The harder I hold, like the more it goes away.
Yeah, so but what that makes you, I bet, a better clinician because like we just said, the ones who get obsessed over numbers, they live in the box. And I think there's a lot there. It's the True Sports Physical Therapy Podcast. Tune in. You might just learn something. Catch all of the full episodes on all streaming platforms. And as always, the link is in the bio.